Welcome, everyone. We're glad to have you here. Hope you're able to log in. You're joining us from both Facebook Live and from here on Zoom, and we're glad to have all of you here. We've got an exciting presentation today. Health Literacy, the Missing Link to Better Patient Outcomes with Dr. Natasha Montpied. This is sponsored by Fullscript, and we have a big amount of gratitude to Fullscript. They help keep a lot of things happening. All the work we do here at AIHM, they're one of our gold sponsors, so we're really grateful. And as everyone's joining in, if this is your first time joining us, you want to know a little bit more about the Academy. We're a global interprofessional integrative health association working to transform healthcare, body, mind, spirit, community, and planet. And this is a little bit of our timeline. And we also encourage all of you to go onto our YouTube channel, youtube.com/AIHM Global. You can subscribe. We put all of our wellness webinars onto the YouTube channel. So those are great free resources for everyone to share or access. And a little special we've got going on, it's an early bird special for those of you who have heard about the AIHM Fellowship program. I get to work in the fellowship. We are starting, our next cohort will begin in April 2023. So we have a special $2,000 off tuition and $100 off the application fee if you mention that you heard about us through this webinar. And that special goes until December 31st. It'll end at the end of this year. So we definitely encourage you to check that out. Take a look at our website to learn a little bit more about the fellowship. And we'd be excited to have you join this amazing group of folks. Now I'll get on to welcoming our very special guest here today, Dr. Natasha Montpied. She's a registered naturopathic doctor with the College of Naturopaths of Ontario. She graduated from the Canadian College of Naturopathic Medicine. She maintains a private clinical practice focused on hormonal and reproductive health. She serves as a medical education and research specialist on Fullscript's Integrative Medical Advisory Team. And she leads a comprehensive, or she led a comprehensive research project on the topic of health literacy, which ultimately culminated into a literature review and large patient survey, which she'll share a bit about today. So I'll switch over. We're so glad to have you here, Dr. Montpied. And I'm going to share, she's here live with us, but we do have the recording of her presentation for everyone. And please, we encourage you to put your questions in the chat, anything that might come up. She's here and excited to answer those questions.
Hi everyone, I'm Dr. Natasha Montpied. I'm a naturopathic doctor and I've been practicing for over 5 years in Ontario, Canada. And I'm also a medical education and research specialist at Fullscript. And I'm really excited to be talking to you all about health literacy, the missing link to better patient outcomes. Now, here is our presentation outline. So first we're going to talk about what Fullscript is, and then we'll talk about the details of our health literacy research project. So we'll be going over our literature review and the results from our patient user survey. And then we'll finish the presentation by talking about how we can optimize patient education, but specifically written educational materials. So first off, for those of you who are not familiar with Fullscript, Fullscript is a health technology platform within the integrative and alternative medicine space, which specializes in improving patients' access to high-quality supplements. However, over the past few years, we've evolved to focus more on medical education and research and finding innovative ways to support the patient-practitioner relationship. Now, I'd like to take you through our research journey, which has led us to studying health literacy. Now, in 2020, our medical advisory team started talking a lot about this idea of treatment adherence and how even highly researched treatment plans wouldn't be effective if patients couldn't follow it. Now, if you follow Fullscript at all, you may have noticed in the past 2 years, we've talked a lot about treatment adherence. And more recently, we've talked about behavioral change and health literacy. Now, just as an aside, if you are curious and would like to learn more about treatment adherence and behavioral change, I've hyperlinked the images of the treatment adherence report and the behavioral change report on the slide to bring you to our toolkits. Now, coming back to treatment adherence. So adherence, first of all, is the extent to which a patient follows a mutually agreed upon treatment plan. So it is different from compliance, which really has this negative connotation where essentially it denotes that the patient is subservient to the practitioner. But as much as we'd like to think that most of our patients follow most of their treatment plan most of the time, treatment adherence research has found that 15 to 30% of our patients are not adherent to a new treatment plan. And 50% of our patients who have a chronic disease are not adherent to their treatment plan. Now, when we take in consideration that 60% of Americans live with at least one chronic disease, that's a lot of people who are not adherent to their treatment plan. And on top of that, 50% of patients will discontinue any treatment plan recommendation within 6 months. And this continues to grow with time. So like I mentioned, there's a lot of people who are not adherent to their treatment plan. And as a result, they are experiencing poor health outcomes. Now, one of the goals of our treatment adherence research project was to identify barriers to treatment adherence. And non-adherence has been traditionally considered a patient problem, meaning the patient is the problem. But we now know that limitations or barriers can actually come from multiple sources. So here we have a diagram from the WHO, which categorizes these barriers into 5 categories. So we have condition-specific factors. So the less severe or noticeable a disease, the lower the likelihood of adherence. We have healthcare system or healthcare provider barriers. So poor communication of a treatment plan, or very short consultations can have an impact on treatment adherence. We have social and economic factors such as financial restrictions and cultural norms. And then we also have therapeutic factors. So the more complex a treatment plan, the less likely a patient will remain adherent. And of course, we do have patient-specific barriers. And today we're going to be talking about health literacy as one of those barriers. And so this is how we came to studying health literacy. It was through our treatment adherence research. So we're going to go through the next few slides. Going to be the results from our literacy review on health literacy. So first off, what is health literacy? The term was first introduced in the early 1970s, and since then, the definition for health literacy has gone through many iterations. But all of those definitions really focused on individual capacity, so a person's ability to read, write, and their numeracy skills. And many argued that we needed to move away from solely focusing on individual capacities and considering health literacy an interaction between the demands of the healthcare system and individual capacities. So here we have a new definition for health literacy, which was proposed by Healthy People 2030. We have on the left-hand side personal health literacy, which is quite similar to past definitions because it does focus more on personal capacities. And so personal health literacy, they define it as the degree to which individuals have the ability to find, understand, and use information and services to inform health-related decisions and actions for themselves. What's new to the definition of health literacy is organizational health literacy. Before I read that definition, I just want to mention that when we think about organizations, we probably think about large institutions like hospitals. But in the context of this definition, it includes everybody that delivers care. So even someone that has a small practice. So organizational health literacy is the degree to which organizations equitably enable individuals to find, understand, and use information and services to inform health-related decisions and actions for themselves and others. Now, studies have shown that approximately 40 to 60% of North Americans have low health literacy. So in other words, 40 to 60% of your patients may struggle to find, understand, and use health information. Now, studies have shown that individuals with low health literacy are less likely to seek out health information. Now, there is some debate regarding whether the reduction in health information seeking behaviors is due to a lack of motivation, reduced access to digital devices and or the internet, or perhaps a decreased comfort in seeking out information, navigating the internet, or interpreting the health information. And likely is probably a combination of all those things. We also see that there's a decreased trust. So individuals with low health literacy are less likely to trust their healthcare provider and the medical systems. And it's been proposed that perhaps the reason for this is that individuals with low health literacy are less likely to see one provider. They're more likely to see multiple rotating providers. And as you can imagine, it would be very difficult to develop a trusting relationship when you don't see the same provider every time. They've also noticed a difference in where individuals source their health information. So individuals with low health literacy are less likely to use credible sources. So one study found that they were less likely to source their information from medical websites and search engines, and more likely to source their information from television and radio programs, social media, blogs, celebrity web pages, and health-related apps and smartphones. It's proposed by the authors that perhaps the preference for these sources is due to the fact that they're updated in real time. Excuse me. So that they're updated in real time. They contain brief information at a lower reading grade, and then it also allows patients to interact, or caregivers to interact with each other and to provide support. Now, individuals with low health literacy are also less likely to ask questions during their clinical appointment about key aspects of their health. And again, the theory behind this observation is that individuals with low health literacy are afraid to reveal the fact that they don't understand what's being explained. And so they don't ask questions. It doesn't mean that they don't have questions, but rather they fear asking those questions. They're also less likely to utilize healthcare services. So one systematic review that looked at females' reproductive health and low health literacy found that females with low health literacy were more likely to engage in avoidance behaviors such as reduced screening for sexually transmitted infections, delayed initiation of prenatal care, and decreased follow-ups after being diagnosed with abnormal cervical cells. And the last thing that we have on this slide is that we've also noticed that individuals with low health literacy in the research, they have a 14% greater risk of being not adherent. So in the past few slides, I mentioned that people have a 15 to 30% increased risk, or 15 to 30% risk of being not adherent to a new treatment plan. For those who have low health literacy, you add on an additional 14%. Now, all of these health behaviors and beliefs can lead to or increase the risk of individuals with low health literacy having multiple comorbid conditions. They have an increased risk of emergency care use and hospitalization, and they also have an increased risk of all-cause mortality. So I have two systematic reviews here for the all-cause mortality. One found that there's a 25% increased risk, and the other one, which was for older adults, found that they had a 27 to 75% increased risk. Now, on this slide, I wanted to highlight 4 different categories of barriers or factors that can influence health literacy. Now, of course, these are not the only barriers, but these are the ones that we want to highlight. So we'll start with the healthcare provider factors. So we as practitioners can have either a positive or a negative influence on our patients' health literacy skills. And specifically, poor communication skills can have a significant impact on a patient's ability to understand and apply the information. So I want to highlight 2 studies that just kind of demonstrate some of the trends that have been noticed in healthcare practitioner communication. So the first study found that 50% of the words used by healthcare practitioners, were technical medical terms, and 79% of those terms were never explained within the context of that clinical appointment. A second study found that 37% of medical terms were used while making treatment recommendations, and 29% of those terms were used while providing health education. So 2 very important components of a clinical appointment. Now, it's been proposed that these poor communication practices may be the reason why 40 to 80% of the information we provide our patients is immediately forgotten, and why 50% of the information that they remember is incorrect. Now, the next factor is education. So although in this presentation, I'll be, especially towards the end, I'll be talking more about educational materials, written educational materials. What I'm about to share in regards to these factors that can influence health literacy, they're also applicable to a variety of written materials. So think about your website, your intake forms, your consent forms, and your treatment plans. So studies have shown that written materials are often written above the 5th grade, which makes them inappropriate for individuals with low health literacy. And this is based on a readability formula, which we'll talk about a little bit towards the end. So the reason why these are inappropriate when it's written above the 5th grade is because often, not always, but individuals with low health literacy have an increased risk of having low literacy skills. And also another kind of factor to consider with education is that finding high quality online information is often difficult. Many websites don't provide citations for the information they're providing. They don't name the author. They don't even publish or write down the date that this information was published. And often the quality of the information is poor and biased. Moving on to the next factor, we have organizational factors. So poor leadership commitment is often a key barrier to creating health literacy friendly environments. So as a result, individuals may struggle navigating the clinic's website, booking an online appointment, or signing into their virtual appointment, or even locating the physical location for their in-person appointment. They may struggle to effectively communicate with their healthcare provider, the staff of the clinic, or even accessing resources like the patient portal or their educational materials. And then the last category or factor that we'll talk about is social determinants of health. So they also influence health literacy. Individuals who are 65 years or older, from minoritized or marginalized racial and ethnic groups, of lower socioeconomic status, those with disabilities, limited education, or limited proficiency in the dominant language will all have an increased risk of having low health literacy. And I just want to do a specific call out to culture because it is something that is often talked about in the context of health literacy. So studies have shown that cultural differences between patients and practitioners can impair effective communication, which would then be impacting really a patient's outcome and the success of that specific clinical appointment. Now, this is the last slide for our literature review, and it's regarding whether or not we should screen our patients for low health literacy. So hopefully by this point, I've convinced you that health literacy is important and low health literacy may be impacting your patients' health outcomes. And so you might be wondering how you could identify these patients so that you can provide them with better care, improve their health literacy, and even improve their health outcomes. But actually, research is recommending that we do not screen our patients for low health literacy. And here I have 3 reasons, and there could be more reasons, but these are 3 reasons that I'm highlighting that suggests or supports the recommendation of not screening patients for low health literacy. So the first one is that health literacy assessments confer more harm than good. So it's been found in some studies that these assessments for health literacy, during the process, patients can feel shame and embarrassment. The second reason has to do with a little bit of some historical context with literacy tests. Now, in the past, literacy tests have been used to discriminate against marginalized and minoritized ethnic and racial groups. And so we can have this negative connotation that's passed down to these health literacy tests. And consequently, we could end up further isolating patients who already face significant barriers accessing care, which is not what we want to be doing. And the final one that I have here is that health literacy is dynamic, and it can actually change throughout our lives and can be dependent on some situations. So we can have high health literacy at one specific moment in our life, and it could be decreased later on in our life, and it could be even within the span of a month be different depending on the situation we're in. If we've received highly stressful information about our health literacy may be lower in that specific situation. And I want to mention one more reason why that kind of supports the recommendation of not screening patients for low health literacy. And that's the fact that all patients, regardless of their health literacy level, will benefit from evidence-based health literacy techniques. And so here the assessment doesn't really change our treatment since we want to use that with all patients. And what we're going to be talking about later in regards to the educational materials would be an example of a evidence-based health literacy intervention. Okay, so as part of our health literacy project, we also surveyed our patient users, and we actually did that last April. So I'll just share some key findings from our survey. So we'll start off with the demographic of the participants. So 86% of the participants identified as female, 76% identified as white, 46% were between the ages of 36 and 55, 94% indicated that English was their first language, 85% indicated they did not have a disability, 86% had a bachelor's degree or higher, and then 30% had an annual average household income between $50,000 and $100,000, and 74% indicated that they either had good or excellent health. Now, obviously, our sample is not representative of the American population. However, it is fairly consistent with other surveys for CAMS users, and it's also very consistent with other surveys that we've done with our patient users. So I've broken down our survey into 3 sections. First, we'll discuss some of the results that pertain to individual skills, so personal health literacy. And next, we'll go over some of our results that pertain to organizational health literacy. And then we'll finish this section by going over some of the educational barriers and preferences that our participants indicated. So we asked our patient users about their self-perceived levels of health knowledge. So we're going to start with the graph on the left. So this is self-perceived levels of overall health knowledge. Now, only 13% of participants rated their self-perceived levels of overall health knowledge as only slightly knowledgeable or no knowledge of these health topics. Now, this rate is far below the North American averages of low health literacy, which is 40 to 60%. Now, it's important to note that this was a subjective assessment or survey, and so it is possible that participants overestimated their self-perceived levels of overall health knowledge. And then on the right, we have self-perceived levels of health knowledge by topic. Now, most participants rated their knowledge as moderately knowledgeable for all of the topics. And moderately knowledgeable is that kind of lighter blue. So kind of, it almost looks like it's in the center. So most of them are kind of, either 45% and higher for all of these topics. Now, fewer participants did indicate being very knowledgeable on the topics of supplement ingredients and environmental health. So if you look at the bottom of that graph on the right, you'll see in the dark green that we have 21% and 19.6% indicating that they're very knowledgeable on these topics. And at the other end of that graph, we'll see in that kind of dark blue, almost black, that there's more people in for those specific topics that indicated being slightly knowledgeable, so 25% and 26% when we compare to the rest of those health topics, which just indicates that for us, we're going to want to continue educating our patient users on supplements and also environmental health. Now, we also, I mentioned at the beginning of the presentation that personal health literacy goes beyond baseline knowledge. And so, because it's really all about those skills of finding, understanding, and applying health information. And so we wanted to ask our patients about their health information seeking behaviors. So we're going to start with the graph on the left again, which shows that 74%, which is a combination of strongly agree and somewhat agree. So 74% of patients felt that online health information is easy to find, which would suggest high health literacy. We also asked participants in regards to how often they search for health information, and that's the graph on the right. And most of these participants indicated that they search for health information a couple of times per week, so 45.1%. And then it's followed by a couple of times per month at 19.8%. And only very rarely, or very low for those who say rarely, 6.4%. Now, continuing on the theme of health information seeking behaviors, we asked our patient users about where they get most of their health information. That's the graph on the left, and which sources do they consider to be the most trustworthy, which is on the right. So left is where do they get information, and right is what sources do they consider to be most trustworthy. So again, starting with the left, the top 5 most common sources of health information are my healthcare provider, medical websites, search engines, family, friends, and coworkers, and medical or scientific papers. Now, the most trustworthy sources of information are, again, my healthcare provider. So that is the most common and the most trustworthy. But then it's followed by medical and scientific papers, medical websites, the Fullscript library and blog, and then family, friends, and coworkers. Now, what's interesting is that despite being the second most trusted source of information, these medical and scientific papers, they're actually not a very common. They're the fifth most common used source of health information. Now, a possible explanation is that individuals realize that these are trustworthy sources, but perhaps these sources are not accessible in the way that the information is too complex, and maybe it's difficult to apply the information from medical and scientific papers, and so they're not used as commonly as a source of information. Okay, let's move on to our questions that looked at organizational health literacy. So we asked our patient users to think about their most recent treatment plan or interaction with their healthcare provider. And we found that on average, 81% of participants strongly agreed with the following 4 statements. So they strongly agreed that they understood why their healthcare provider recommended their treatment plan. They understood the treatment plan instructions. They felt that they were able to easily carry out the treatment plan instructions, and they felt comfortable asking their healthcare provider questions about their health or their treatment plan. Now, we can't say for sure, but we have a few theories as to why we're seeing these results. One, it could suggest that these patients or participants have high health literacy, which is why they have most of them selected strongly agree with these statements. A second reason could be that the practitioners that these patients see practice effective communication. Therefore, we would see a similar pattern with all patients, regardless of their health literacy level, if this is the case. And of course, it could be both, right? We can have patients that have a demographic or survey participants that are highly health literate, and also their corresponding practitioners being practicing very effective communication as well. So next, we inquired about how frequently our patient users receive education material from their healthcare provider. And we found that, looking at the graph on the left, that 66% of users received education materials either somewhat often or often. And on the right, 94% of users felt that the educational materials that they received from their healthcare practitioners were easy to understand, which again may speak to either the fact that the patients we surveyed have high health literacy, and or the education materials that they're receiving is of high quality, and therefore all patients are benefiting from the high quality information. Now, lastly, we wanted to see if patients felt that Fullscript created education materials were easy to understand and if they helped them carry out the instructions of their treatment plan. So starting with the graph on the left, so we can see that the participants who reported often receiving Fullscript created education materials were more likely than any other group to indicate that the education materials are easy to understand. So I'll just kind of direct you for that graph on the left. If you look at the bottom, we see often, and that indicates how often they receive educational materials. And then on the vertical axis, we see that this is indicating whether or not patients feel that it's easy to understand. And so 89% of people who often receive Fullscript education materials are saying that these materials are easy to understand, and that is highest compared to all other groups. And then the graph on the right, we see that participants who often receive Fullscript created education materials were more likely, so that's about 87, but it's 86.5 on this graph. So they're more likely to strongly agree with the statement, I was able to carry out the instructions of the treatment plan easily, compared to those who, especially compared to those who never received those educational materials, which was 64.9. So although it's not a direct measure, these results suggest that the Fullscript created education materials may help patients carry out the instructions of their treatment plans, which would be helping with overall treatment adherence. Now, this is the last section for our survey that we'll discuss, and it's regarding our patients' barriers and educational preferences. So we asked our patient users what barriers prevent them from searching or finding health information. And so the top 3 barriers, which you can see in the highlighted in the red, we have, I'm not sure where to find reliable health information. I don't have enough time to look for health information. And then the third most popular choice was other. And on the right-hand side of the slide, we have some of the responses that our participants provided. So some indicated that they were not being able to trust or not trusting the information, the source of the information. Some had condition-specific barriers, so brain fog preventing them from seeking out information or understanding information. Patients indicated that they felt overwhelmed by the amount of information. Some didn't feel motivated to take a deep dive and triple check information found online. And that goes back to that theme of trust. Some individuals indicated that not having free access to medical journals is a barrier. And the last one being not being able to find reliable studies. Again, kind of trust being an issue here. Now, regarding educational preferences, so surprisingly, the majority of our participants indicated that they prefer receiving written educational materials. So you can see that on the left, in the left graph, 59.6% preferred written educational materials, which I was surprised. I was expecting to see more videos being kind of the majority of what participants preferred. And on the right-hand side, we see that participants preferred more short to medium length materials. So we defined short as being it takes less than 5 minutes to consume, and medium between 5 and 20 minutes. And so there's a preference for those 2 lengths. Okay, so let's move on to how we can optimize patient education. And so we're just going to go on to the next slide here. So first off, what is patient education? It's the process of influencing patient behavior and producing the changes in knowledge, attitude, and skills necessary to maintain and improve health. So as you can see from this definition, patient education is not defined by a specific format, but we're going to focus mainly today on written educational materials. Now, why does patient education matter? So some studies have found that providing patient education can improve quality of life. It can enhance treatment adherence, lower all-cause mortality. And although the last bullet here is an older study, is just kind of to show that it can help with healthcare savings. So this specific study back in 1995 found that every dollar invested in patient education saved $3 to $4. Now that could be different today, but just to kind of illustrate that as a factor too. And in the context of our presentation today, we're hoping to also enhance health literacy, which would then enhance patient outcomes. Now, an important consideration or question that we should be asking ourselves is, do all patients benefit from health education? Now, despite having the most to gain, patients with low health literacy benefit less from educational interventions compared to individuals with high health literacy. So for example, one study found that there were smaller increases in gynecological cancer symptom awareness in individuals who read a handout on the subject. So there was less of those gains in people with low health literacy after reading a handout on the subject compared to individuals with high health literacy. So this study doesn't show that we shouldn't provide our patients with low health literacy educational materials, but rather that we need to consider their specific health literacy needs when we're putting those materials together. And as I mentioned earlier, this will not only benefit people with low health literacy, but it's going to benefit all of our patients. All of our patients will benefit from educational materials that consider health literacy. So this brings me to the 6 steps for creating or sourcing health literacy friendly education materials. So these steps are also relevant to individuals who are sourcing their health information. You can kind of use this as a guide to determine whether or not this material you've sourced is health literacy friendly. So let's go to step 1. And you'll see some of these steps kind of mirror our survey, the survey results that we've talked about just a few moments ago. So before you can create or source health literacy friendly educational materials, you need to know your patient population. Who are you creating this information for? So you can gather some of this information. We did it through a survey. Maybe if you're using an electronic health record, you can get the demographic information from there. Having this information will help you provide culturally relevant and appropriate educational materials to your patients. So here's just an example of different things you could be asking your patients or collecting. So their age, income, culture, disability, their gender, their location, race, ethnicity, and their preferred language of communication. Next, you want to identify your patient population's educational needs and preferences. So here, again, very similar to the questions that we talked about in our survey, but what delivery format do they prefer? What length of information do they prefer? What language do they prefer to have their educational materials in? It could be different from their language that they verbally speak. Do they require accessible content? So something that's compatible with a screen reader. Do they have a preference for digital or hard copy resources? And that can be to the fact that maybe they don't have reliable access to digital, like a smartphone or the internet, or perhaps they don't feel comfortable using digital devices. And then what barriers prevent them from searching or finding or understanding health information? So as we kind of alluded to in the survey, so it could be maybe they don't know where to look, maybe they don't have enough time, maybe the information is too difficult to understand, perhaps they don't have access to reliable digital devices or the internet, or maybe they have issues with navigating the internet, or they don't feel comfortable or confident. Next, let's talk about how we can clearly communicate our message. So it's important that we give the most important information, first on our handout. And we want to repeat that throughout our handout as well. And we want to use clear everyday language. So we do want to use, and by that I mean we want to avoid using medical jargon. Now, it is acceptable to use medical terminology as long as we're first defining it using plain or everyday common language. So for example, we have here, you want to say high blood pressure, not hypertension. But if you want to, expand your patient's vocabulary and kind of have that as part of the education, you could say, hypertension, and then you can put your high blood pressure in parentheses. So it is okay, but you have to, again, define what that is. Next, you want to limit the number of messages in your document. We don't want to overwhelm patients too much. As I mentioned earlier, 40 to 80% of the information we provide our patients is immediately forgotten, and 50% of that information is remembered incorrectly. So we do want to reduce overwhelm and enhance or increase the chances that they'll remember the information correctly. And it's also a good strategy for increasing adherence, which we'll see later as an example. So a good way to know what to prioritize in your handout would be to ask yourself, is this a good to know piece of information, or is this a need to know? And you want to prioritize putting all of the need to know information into your handout or your educational material. You also want to use an active voice when you're writing, and you want to use a positive tone. So an active voice would be, I have an example here on the slide, take your medications at noon versus medications should be taken at noon. That's one of my kind of weaknesses. I tend to write in passive, and it could be difficult for a patient, especially a patient with low health literacy or low literacy skills, to determine what actions they should be taking. And then most people react better to when we use a positive tone. So positive tone would be eat 1 serving of vegetables with each meal versus do not forget to eat 1 serving of vegetables with each meal. So kind of just using that positive tone throughout, and also just kind of always using more of a positive approach to your materials. So instead of focusing on perhaps how many individuals die from a specific condition, you can talk about how you can improve your chances of decreasing the risk of that condition. So trying to put a positive tone. You want to use also familiar analogies. So for example, we have here another example, feel for lumps about the size of a pea, and not use the sentence feel for lumps about 5 to 6 millimeters in diameter. So it's much more familiar with the size of a pea. You want to avoid any unnecessary abbreviations. So if you do end up using abbreviations, you want to write it out first. So if you're using IBS, you're creating a document on IBS, you want to write irritable bowel syndrome, put your IBS in parentheses, and then you can use IBS throughout the document. I do want to caution individuals as not using too many different abbreviations because it can be very confusing to remember, what did IBS stand for? What did PCOS stand for? And so on and forth. And then we want to use short sentences in paragraphs. So our sentences should be between 8 and 10 words, and our paragraphs between 3 and 5 sentences. If you can put a semicolon in your sentence, likely you can replace that with a period, and that's going to greatly improve the readability of your material. Next, we want to talk about how we can draft health literacy friendly education materials. So we have 2 slides on this. So first, we want to use easy to read fonts, so between 12 and 14 points. We want to make sure that our headers or our subheaders are clearly headers or subheaders. So with that, we try to increase the size. At least they should be 2 points larger than our main text. We want to use, there's some debate here, but there's some people that indicate that we should use sans serif fonts for digital resources, which is what we have here on the slide. Or for printed out or hard copy resources, we should use serif fonts, which would be Times New Roman would be a serif font. We want to try to avoid using all caps or underlying or italics when we want to emphasize a statement and rather bold that information. And then when we're thinking about design and layout, we want to use dark lettering on a light background. We want to break down our lists, so only 3 to 7 items per list, which is an example on this slide and the next, rather than having all this text just all in one list. I've broken it down with some subheaders, so it's easier for you to scan. And similarly, in a handout, it would be easier for a patient to scan which list is relevant, where to help them find the information on the handout. You want to use plenty of white space to enhance your readability. And we have an example of that on the right-hand side. The image that's slightly higher, there's a lot of white space, really enhances readability. The image on the right lower area, very narrow margins. And so you can imagine there's a way more text. And so that would be really more of a strain on the eyes, and also it would decrease readability. And we also want to avoid using justified margins, especially for individuals who have low literacy skills. The uneven spacing between words in a sentence can really throw them off. And this last section for drafting has to do with images. So we want to use our images effectively. So images should enhance our message rather than being purely decorative. We should be showing our audience what to do or take versus what not to do. And we have an example of that on the right. So the caption is eat more fruits and vegetables. We want to show our patients fruits and vegetables that they should be consuming, whereas image B indicates what they should not be consuming. And a second thing in regards to image B is that there's that circle with a line across. So we're using a symbol, and a caution with the use of symbols since they're not universally known in regards to what they mean. And so a patient may not understand what a circle with a line across means. We also want to use culturally appropriate images. So basically our images should represent our patient. And so this is where the information from the demographic information of your patient population can be very handy in sourcing images that represent them in regards to their race, their age, their gender, and even their disability status. We want to label all of our images with a description, so have a caption, and that caption should have our key message. And we want to present one message per image, so one key message per image. And if you have a lot of patients who are using screen readers, you'll want to definitely insert or use alt text for your images so that when the screen reader gets to that image, it reads out that text so the patient knows what that image is. The next part is that we want to test our educational materials to make sure that we're on the right track. Now, of course, this could be kind of an overwhelming step, especially for practices that have one or two practitioners, because you have a lot on your plate. However, I've put quite a few different options, and I'm hoping that you may find one that works best for you. Now, I do want to encourage you to kind of at least explore these different types of assessment tools, because like I mentioned, it is a good way to know if you are creating indeed health literacy friendly educational materials. Now, the first category is readability formulas, and I have a few formulas here listed on the slide. And essentially, these formulas focus on the length of words and sentences and estimate how difficult the text is to read. Now, the positive thing of these readability formulas is that they're very easy to use. You can find some free calculators online, so you basically just copy paste your text into the calculator, and it will give you your reading score. If you use Grammarly, they also have a readability formula. You just have to actually open up their app and put your text into the app, and it will give you the readability score. Now, the downside with these readability formulas is that they don't really tell you how to fix your content. It tells you, maybe your words or your sentences are too long. But other than that, it doesn't really give you a lot of information. The next one is the understandability assessments, and they are much more comprehensive, so they do take more time and they're not automated. So it is more of a manual process. They have kind of a questionnaire that you answer as you're reviewing your educational material. However, the positive for this is that they're, like I mentioned, much more comprehensive. So you have much more actionable information as to how you can improve your educational material. Now, here I have a few different examples. So PMAT is the Patient Education Material Assessment Tool. So that's mainly for written educational material. And then they have the AVU is for audiovisual tools. The SAM is more for suitability and cultural appropriateness. And then we have the CDC's Clear Communication Index. And then the last category, which I think is the most important, and if you were to only prioritize one of these assessment tools, I would say definitely patient feedback, as patients are your endpoint consumer for your educational material. Now, you can do this informally. So at your follow-up, you can ask your patient what they thought about the handout. If it was easy to understand, if the handout suggested for them to take any actions, and was it clear what actions they should take. If there was, anything that was offensive, or any types of questions that you were most interested in knowing about your handout. You can also do this through more of a formal way. So here we have a patient feedback form. It's 3 pages. The first page is more of a feedback form for communication, so they can evaluate your communication style. The second page is where you have the feedback on educational materials. And so you can provide this assessment along with their educational materials, and you can ask them to fill out the questions as they're going through the form. And the third page is just kind of more of an open text that they can write any type of comments or feedback. So that's another way that you can get feedback from your patients. Now, before we move on to the last step, I just want to share with you Fullscript's readability and accessibility project. So in early 2022, we contacted the Center for Health Literacy at the University of Arkansas for Medical Sciences so that we can have a comprehensive assessment and also have our education materials assessed for the use of plain language. And with the information from that assessment, we modified some of our handouts, and then we conducted field tests and gathered feedback on comprehension and the reader experience for both the original version of that content and the modified content with that we received the feedback from the Center for Health Literacy. And using the insights from our field testing and from our assessment with the Center for Health Literacy, we are currently developing guidelines to improve the readability and accessibility of our content for our patients. And the next step is that we hope to determine whether or not the optimized educational materials are going to increase patient engagement in the platform. So we're really excited to see what happens there. So this is the last section, how to use educational material effectively. So this is a little bit of 6 tips. Some of it has to do a little bit more with our verbal communication when we're verbally communicating education to our patients, and then some things regarding specifically written or like more written educational materials. So unfortunately, just providing our patients with educational materials is not enough to increase their health literacy. So this is where these 6 tips can come in to enhance patients' health literacy. So first, we want to use clear, everyday, non-medical language when we're speaking with our patients. So it's not just for our written educational materials, but also when we're speaking with our patients during their clinical appointment. And we want to speak clearly at a moderate pace. And we could even use our patients' own words, the words that they use to describe their condition during the appointment, so that they're not confused and we know what both of us are talking about. So if they're referring to their diabetes as their sugars, you can refer it to that as well. And if you want to kind of educate your patients on diabetes is, high sugars, then you can do that as well. As long, again, as you're defining what diabetes is using everyday common words or using their own words. You want to limit your key points that you discuss to 3 or less to avoid overwhelm. And that, again, comes back to the fact that patients immediately forget 40 to 80% of the information that we provide them, and then 50% of that information is remembered incorrectly. And this is also a great way to improve adherence if you apply that to your treatment plan. So three key points or less for your treatment plans. Now, we also do not want to solely rely on educational materials. Educational materials are supplemental. They don't replace verbal instruction or education. Now, that's really important. Patients with low health literacy often have low literacy skills, as I mentioned before, and so they often rely on verbal instructions. Also, something that I encounter frequently in my practice is that there's no guarantee that your patients are actually going to consume, read, or watch or listen to the education material you've provided them with. And so it's really important too, which brings us to point number 4. It's important to review the educational materials during your clinical appointment. And especially if it's kind of a written document, whether it's virtual, a digital resource, or a hard copy, you can mark it up, indicate to your patient, this is where I want you to focus, like reread this particular section. And then you can provide that, either the hard copy with all those highlights and marks to them so that they can easily refer back. Or if it's a digital resource, there are a lot of programs that allow you to mark up a document. You could save it and send it to them. And so it's easy for them to go back to the key points, especially if it's a longer handout that you're providing them with. Also, you want to refer back to these resources at your next appointment. This emphasizes the importance of the education material that you provided them, but also it gives you an opportunity to verify understanding and answer any questions they may have. Next, you want to encourage question asking. Like I mentioned, individuals with low health literacy are less likely to ask questions, and it doesn't mean that they don't have questions. It's just that they may fear revealing the fact that they don't understand. And so you want to do that by using open-ended questions. What questions do you have versus do you have any questions? What questions do you have really implies that you're expecting questions, you're open to questions, and you're ready to answer them. And it really enhances the chance that your patients will feel comfortable asking those questions. And then the last is that we want to confirm understanding. Now we can do that by using the teach-back method. And I've hyperlinked the toolkit for the teach-back method, which goes into much more detail. But briefly, the teach-back method is we have patients either repeat or demonstrate back the information or technique we've taught them. And so it's really important that we destigmatize this interaction and we place the onus of clear communication on ourselves. So we're not testing our patients, but we're making sure that we did a good job clearly communicating, for example, their treatment plan. And one way that you can destigmatize this interaction is by saying something like, I've just said a lot of things to make sure I did a good job communicating or explaining things clearly. Can you describe to me how we'll be taking, for example, inositol, or why we're taking inositol and how we're going to be taking it? And that if your patient gets some of the information incorrectly, you can try a different way of explaining the information and then have them repeat it back to you. Now I just want to spend the next few slides just showing you how Fullscript can help you effectively deliver patient education. So we have over 150 patient resources in the library. We have guides, we have handouts, graphics on topics ranging from nutrition to lifestyle and supplements and specific health conditions. All of our resources are developed using the latest evidence, and they are routinely updated. They're fact-checked and vetted by our Integrative Medical Advisory team, and I'm one of those people that does some of the vetting of the educational materials. And they're also designed in-house to ensure that we have a consistent patient user experience. Also, you can attach these educational materials directly to your treatment plan within the app. You can also download them. So if you want to upload them to your own EHR or print them out for your patients, you can do that as well. You can attach them to protocols. So if you are using protocols in Fullscript, and for those who are not familiar with protocols, we have pre-designed protocols. So for example, we have one for ovarian health, which is PCOS, and we have the kind of the top researched products in there. And you can attach your own handouts to that. Some protocols, we've attached handouts. And you could create your own protocols, and you can modify the protocols as well that we've created to reflect the brands that you want to use and the specific ingredients you want to use. So you can certainly attach your own handouts or the Fullscript created handouts to those protocols. And then lastly, as I kind of mentioned a little bit a few seconds ago, you can upload your own educational materials to the Fullscript platform and attach it to protocols or attach it to treatment plans as well. So you kind of create your own little library of resources. Now here I'm just going to show you how you can access the resource library. So there's two different ways. You can go through the main page and go through prescription, resource library, and here you'll see the entire collection of our educational materials. And here you can just see a little selection. You can go through and select a specific category, so only those handouts with that topic will come up. You can select alphabetically, or if there are newer or older resources, and then the type. So if you are looking more for a guide, a handout, an infographic, some meal planning, or some worksheets. And you can also use the search bar to type in keywords and see what comes up. So here we're looking for the paleo diet. And we found two, a guide and a handout. You can, I'm just going to wait for it to do, so you can download it or you can view it, and that would pop up in a separate window if you press the view. You can also access the resource library through the treatment plan tool. So here you'll see attach a resource. And you can, again, there's the categories. If you want to go by category, there's the search bar. You can put in your keywords. Again, we're looking for the paleo diet. This time we're looking at the handout. On the right-hand side, we can see the handout. We can again open the document, which would help us see more in detail what's the handout. And then we can see that there's two handouts that we've attached. We have our prescription. So if there's only a few things to remember, I would like you to remember that low health literacy is very common. 40 to 60% of your patients likely have low health literacy. So 40 to 60% may struggle to find, understand, and apply health information. The second thing is that you want to consider your patient's health literacy needs when creating or sourcing educational materials. And you want to use those materials with all of your patients, regardless of their perceived health literacy. And then you want to ask for feedback. You want to ask your patients, your peers, and your staff for feedback on your communication style, your educational handouts, your website, your patient portal, whatever it is that you want to optimize. And here I just want to finish with some of our health literacy resources. So we have specifically developed tools to help with your patient or to support your patient's health literacy skills. So we have handouts on dietary supplement quality, how to read a supplement label, tips to how people can follow their treatment plan, so tips for adherence, and then how to spot credible sources. We have some information for social media and as well for research articles. We have some resources for oral and written communication, and I do want to bring your attention to the sources for clear, plain language, so the third bullet. And here are sources, websites that you can use to find alternatives to your medical jargon. It can be sometimes difficult to figure out what would be a common word for a medical term that you've always used. And so this could be a great way to find some alternatives for your medical jargon. And here we have the last one, which is assessment forms, which I've kind of mentioned at the beginning or throughout the presentation. So we have a practitioner communication self-assessment and peer feedback form. So the self-assessment you can do following an appointment, and it's just kind of a reflection on your communication style. And then from that information, you could try to improve on certain aspects and then reassess yourself in a few months. And then we have the peer feedback form, which is you invite a peer or a colleague to evaluate you during an appointment. But you always want to make sure that, of course, you ask consent from your patients and that you emphasize that your patients are not being evaluated, but your communication style is being evaluated. And then we have the patient feedback form, which I described earlier, which we have a section on where they can evaluate your communication practices and also your educational materials. And so those are all there. They're all hyperlinked, and hopefully you find those resources very helpful for you. And that's it. Thank you very much for your time and attention. I look forward to answering your questions. And here we just have some of our references that we've used throughout this presentation and that we also used in our health literacy project. Thank you so much.
Hello, thank you so much, Dr. Montpied.
Thank you.
Yes, lots of activity here in the chat, a ton of links and resources you've made available. We really appreciate that. And again, if anyone has questions and you are able to get those into the Q&A feature, it's easier for us to capture those and get them asked than in the chat, but we can do our best here. I did see one question, and we can move into that from Michael. Asked, once an article is read, what are ways they are encouraged to retain the information and keep a record of changes they've made in their lives as a result of learning this information? Or do you have any thoughts to add to that question?
Yeah, I have a few things. So the first thing is that potentially referring back to some of these documents. So let's say you've given your patient a handout on a specific type of diet that you want them to follow. Perhaps it's, let's say, a vegetarian diet or something like that. So referring back to the handout, not just after the first appointment, but throughout your interaction with your patient. If you do any email follow-ups, or some practitioners do some sort of like text follow-ups, those kinds of things, those touch points between appointments can be very helpful to remind the patient to not only, I mean, this is a question about behavioral change, so that's a little bit separate. So you may actually find our toolkit on behavioral change very helpful for this aspect, but referring back to the document can really bring that back up into your patient's mind. I've definitely had a lot of patients who've forgotten that I gave them a handout on a specific topic for whatever type of treatment recommendation. So referring back to it can be very helpful. But also the way that we design our educational materials, like I mentioned throughout the presentation, can also really enhance patients to remember. So you don't want to overwhelm and bombard them with 10 or 20 different types of key takeaways from that handout. So focusing on 3 things in the context of, let's say, a vegetarian diet, it could be, you know, eat 3 vegetables per day, because a lot of people who do the vegetarian diet do more of the fake foods replacements, right? So you could focus on 3 key takeaways that they should take from that particular handout if they're trying to adopt a vegetarian diet. So that can be very helpful. I was just writing some things down when I was reflecting to this question. Another thing that could be helpful for your patients is that maybe they can create their own little resource library. So whenever they receive some piece of educational material from you, either if it's a physical, they can have a little binder that they refer back to, maybe all their treatment plans are in there, or perhaps if they're more kind of digital literate, it could be having a special folder in their email or on their computer where they can just kind of gather their information. And so that way it's a little bit easier to return back to that information. So some sort of little kind of resource library can be helpful. And I think that's everything I had written down for that. Oh, the other thing,
yes,
tracking.
Sorry, go ahead.
This tracking sheet. So if you're, if it could be maybe physical activity, the benefits of physical activity, having them have a tracking sheet, that could be something that could be very helpful to just keep track of things. But like I said, the behavioral change paper would be also really great to connect with the health literacy component.
Yes, and we did a previous webinar about the behavior change as well. So that's also on our YouTube channel too, if you want to check that out. And like, this is so important for accessibility and just like pushing forward health equity and making sure people are able to access the information they need. It's appropriate for them and is ultimately going to make those health outcomes, you know, available to them and make those changes that they need to accomplish. So really incredible. Thank you so much. I'm going to actually close this out. I don't see any other questions. So one moment here, and I will pull up a couple more slides that we have as we are grateful to everyone who's joining us. This is our last webinar of the year. And we, as I mentioned at the beginning of this presentation, we have huge gratitude to our gold sponsor, Fullscript. They're clearly doing a lot of work bringing health equity, which is really important to AIHM as well here at the Academy. And their sponsorship is what makes our work possible. So we just have huge gratitude to you. And Also, just a reminder, we've got in January, our Heal the Healer retreat is coming up. So if that's something you are interested in, you need some rest and rejuvenation and connection, we encourage you to check that out and register. And yeah, we are here in this together, building a global community, leading integrative health globally. We encourage you all to get connected with us, because imagine the change that we can make when we all work together across the globe, synergizing and amplifying integrative health. And these are all the different ways you can get connected with the Academy. Again, I mentioned our YouTube channel. Our AIHM Global is the tag we use for all social media platforms. You can become a member and you could join a chapter and get involved locally. We just really encourage that. So huge thanks to all of our community. Again, to you, Dr. Montpied, and to Fullscript. We just are wishing you all a really happy new year and a wonderful weekend. Bye.